there's a tweak to the title, which is, and you'll see why, is because when I was putting this together, I was like, I need to figure out who I'm presenting this to, and that I shouldn't really sell myself as someone who knows what he's doing when it comes to models. Um, so I have tweaked my title to to align with what I really do, which is sort of as part of my role, looking into how we can use the data that is produced by the NHS more effectively. And in doing so, I will go through a whole host of examples that I used at a few NHS trusts, and the context within which we are working in the NHS. I imagine that most of this will not be new to you. Examples of the work that we started to do during COVID, and the manner in which we are segueing that to healthcare associated infections. My struggles with introducing anything that has the alphabets A and I in the NHS. Well, mostly because I understand so little of it. I think that must be the main issue. But first things first, what I am and what I'm not. I specialize in healthcare associated infection epidemiology. And as part of that, I look at antimicrobial resistance. And right now I'm doing a few roles. So I work part-time for the NHS as the epidemiologist. And I think, well, most of all, we'll sort of know what a epidemiologist does, but we can touch on it because actually the role is quite open to change according to the institution you work for and what your expertise are. But what I'm not is a modeler. I'm learning. I'm sort of in the beginning stages, and I have tried and failed. So um, um, more than I've tried and not failed at this stuff. But I do promote the use of data. So, and if that means that I need to sell automation as the gateway drug, well, I do. So epidemiology is spans a really broad portfolio of activities. Because I'm a epidemiologist that has primarily been clinically focusing, so I have worked within the clinical sector since since 2007. And that means that I have primarily worked for the infection control, the department as a epidemiologist, so trained as so first at Imperial, and then I recently moved to Sussex. And what that means is you do a whole host of things, right? You look at the surveillance of healthcare associated infections in, so my case, you build monitoring systems. Um, um, well, you look at the occasional the epidemic and pandemic, so as we all have to. But a lot of the bread and butter is how do we use data and how do we help our clinical staff to manage outbreaks, right? And we'll come down to what these are and how they present themselves. But there's a huge amount of communication, right? And the lack of communication is, in my mind, one of the biggest barriers to the use of anything. And a huge part of my job, it seems, well, as you get older, you need to be well able to speak more and more, which is not really my thing. But the point is that being able to communicate the use of data, and actually what you can do with data, moving on to things like machine learning, is not easy, right? And it's not easy within a context. So we've already we focused on this. My focus is to use data, make data more approachable. There's a huge struggle within the NHS, which we'll touch on, and I am doing some work with automation. Although I am the communicator for my sins rather than the person who actually does the dirty work. but we can invite those people too at a later date if you want more details. But yeah, but happy to share details. But here's the clinical context within which the NHS works, and this is a pie chart from a few years now from the European Centre for Disease Control, and it essentially shows what as the NHS or any or any system that is within Europe is facing in terms of the clinical context. There's a lot of pneumonia. There's a lot of UTI. There's a lot of surgical site infection. We all know about the bloodstream infections. We have GI infections, and not to mention the fact that we have sepsis. We have mpox, we have norovirus, we have the respiratory viruses. So it just seems that on one side we have a job for life because things seem to be going from bad to worse, but on the other side we never seem to be getting ahead of it. All clinical services are always at the back foot, and sort of my role or what I'm trying to do is how do you segue from the action-led infection control role to the preventative role, right? And that is not easy. And this is just sort of looking at one of those at the bacteremias in more detail. I hope everyone is comfortable with the word bacteremia. Do shout out if you're not, but essentially they are bloodstream infections, right? And bloodstream infections, for the most part, have been going up, and the only dip we had was due to COVID, right? So the Staph aureus infections, our C. difficile infections, which live in the gut, Pseudomonas infections from water, the Klebsiella infections from catheters, and E. coli, especially, you would have all heard. The bacteremia rates are going well up and up and up, right? So the NHS, being underfunded as it is, has having to sort of deal with year on year this accumulation, right? Because the patient population as a whole is getting sicker. But let's move on to the positive sides, right? We have a lot of data because we see a lot of patient contact. And at every point in which two patients meet each other, or the patient meets the hospital, the interactions we see at the GP surgery, the community, the mental health, it's all producing humongous amounts of data. Now that sounds great, right? But I mean, I don't have to tell you that what the challenges are in terms of using the data. The other the challenge that I just wanted to touch on, as in to build the context around this, is that the decision making in the NHS is not an easy one, right? And that so if you take the IPC team in the middle where I work, these are just a number, and it's not exhaustive in terms of the people who I am answerable to, as someone who has been put in charge for my sins to lead on building a more prevention and predictive focused infection control workflow, right? Sounds great on paper, but it's it is a hard it's a hard sell, and the NHS is driven by making sure that the clinical service that it gives its patients is are actions, are the antibiotics, and are the processes which are driven by evidence, right? So one of the things to understand is if you want, if there is to be any any level of innovation within the NHS, you're sort of in this chicken and egg scenario where you almost have to build the evidence that something works within the NHS to actually sell it to the NHS. Even as someone who is the insider within the NHS, that I almost need to have built something, have the clinical evidence that it works within the NHS for the NHS to want to do anything about it. So, and that's not easy, right? And of course, we are cash strapped, right? Which you would think is a really good driver for using data. So, and it is. It is. Things are changing because, of course, we cannot. So possibly we don't have the money to hire more nurses. In fact, we're losing nurses. Um, so what do we have a lot of? We have data. So it is a cell. So one example, and apologize to those who came to this presentation so looking for in-depth use of models. But it is it's gone down a few levels, so I do apologize. But one of the ways in which all hospitals should be using their data, right, is they should be using their microbiology data in everyday um, in the everyday uh, surveillance of outbreaks, right? At any one point, we are a 1,800 bedded hospital at University Hospital Sussex hospitals. We are 4 hospital sites and numerous other units, right? So at any one point in the hospital, we have about 2,000 patients. We always almost run at capacity, right? So we have 2,000 to 2,500 patients. A lot of these patients are coming into contact with one another, right, at various points. They are all in a ward together, right? Um, and so the transmission of infections is not an if, but when. It's happening all the time. And so if one of the things that I have made it my job to do is to make sure that microbiology data is being used, regardless of the quality of that data, being used to understand what is happening, or use the microbiology lens to understand what is happening within our patient cohort every single day. So when we come in the morning, so to give you some details, a lot of the microbiology data within the NHS, and we will touch on it, is heterogeneous. It is interoperable. It is in multiple systems, right? All 4 hospitals use all sorts of systems. So the thing that I've been able to do in my role is to put together some R code so that I can utilize the sort of non-formatted nature of the microbiology to at least mine for key variables so that I can start building a log of first patient, first case, and then so on and so forth, so that we can then apply, we can then we can then apply some intelligence to it. So, for example, if we have 2 infections in the same ward within 7 days, that should trigger a prompt for this might be transmission. Yeah. So and so on and so forth. And so you end up with a scenario, hopefully, where where you where you don't have to deal with the yellow with the yeah. But the problem is the microbiology data, the way in which it is presented. And so, for example, one of the biggest issues that we are dealing with within the Hospital Sussex is that, so even though we've been lucky in terms of our burden of multi-drug resistant organisms, but because we are close to Gatwick and we are close to London, so invariably we are seeing a rise in our CPEs, and our CPEs are our carbapenemase producing Enterobacter raleigh. So these are highly resistant, so E. coli for that matter, right? But the way in which the microbiology system reports CPEs is varied, right? And it's almost always in free text. So what do you do? The second example of the work that we have started to do is, and this is something that we took from COVID. You will recognize the fact that during COVID, a lot of the actually all hospital trusts who could manage it, at that point, I was at Imperial, that we had to make sure that when we report COVID to Gold Command for the infection board within, for example, where you are, so the London Infection Board, and this had to happen every single morning, that we couldn't just report the COVID cases in terms of the incidences, right? We had to figure out what were the hospital onset infections, and how do we separate that from the community well onset infections, right? And so what we had to do is we had to use the microbiology data, but we also had to bring together the admission data of the patients and the pathways of those patients. So we could essentially drop the microbiology within the pathway of the patient to understand whether this is a community-borne infection or a hospital-borne infection. And so these four colors are and it's really well helpful because actually, if you start from the bottom down, the top is the community stuff, right? And far from it being gray, it's actually the most important bit because that community so prevalence of an infection is what is driving the oranges and the reds, right? There was a time when we used to go, it's, these are the community infections, no matter, we need to focus on the reds. But actually, that is the driver. The grays become the oranges and the reds, right? And we're applying this to healthcare-associated infections. So right now, we're doing something very similar for C. difficile. The other thing that came out of, and these things, must be routine at your end, but for the NHS, largely in my sort of coming to 20 years, the Central London hospitals and a few other hospitals are really good at using their data because they have more money, and they have also been able to get big big systems like Cerner and Epic in, right? Mm-hmm. All the others have had to sort of do this by themselves, largely because the budgets are smaller. And so one of the things that came out of COVID was, why aren't we using our pathways for the patients to understand the overlap of the outbreaks, right? And so you would have so notice that on the y-axis, the vertical axis, you have patients, and then on the horizontal axis, you have time. And this is not and this represents a outbreak, right? And each of the colors is a ward. So we have 4 wards here, and the diamonds are when the patient became positive, right? And so this is humongously well helpful. It might be simple in terms of how it's put together, but I can't tell you how few hospitals within the NHS have this, because it requires it requires a role like mine to dedicate to be able to use what is often unstructured information from microbiology, from the patient administration system, have a background in coding, to be able to do this, because a lot of the hospitals almost accept or expect the nurses to I wouldn't say make do, but you get the point. To be able to do this in their spare time, it is almost impossible. So, which is why we see this sort of huge import of, EPRs like Cerner and so others, Careflow, because actually they might do some of the job for us, but actually this is the kind of thing that infection control needs every single morning, right? It needs to be able to tell what is happening, what are the relationships between these patient microbiology and what are the patient flows. This is some of the work that I did for the Scottish government. I can't speak about exactly the details of that work because I'm still working from, but fair to say that it was not surprising to me that the issue regarding use of data, in this case, the data around water positivity, so the environmental samples for water, being provided in a manner that you can use and overlay on top of the purple line, which is the undulations in the infection rate, right? I mean, it doesn't take, it doesn't take a genius to figure out that if you're looking at infections that are born out of waterborne pathogens, that you need to be able to look at the water positivity rate, which is a measure of these pathogens in the water, and do some simple look at look at the coefficient of correlation, do it with a delay to figure out how the infectivity rates within the water or the positivity rates within the water so align to the positivity rates of that infection within our patient population, right? So I don't think the cell is the problem. It's the fact that the data is not interoperable. It's not available in a format that is usable, right? So when we come to AI, I mean, we are a long way from the use of AI, the use of even so advanced models within the NHS outside of the research scope, right? And I have to say that because there's a lot of excellent work going on, but if you have a look at the research articles on do you have evidence of clinical effectiveness, right? Do you have evidence of implementation? Um, is it a model, a output, a framework that is applicable to more than one hospital? The answer to all of these will often be no, because the data differs between hospitals. I mean, the data you will be looking at similar data, but the formats will differ. The context will differ. The patient flows will differ. The burden of infections will differ. Um, and so there's a huge amount of anxiety. There's a huge amount of excitement, but there's also a huge amount of also there's a space for pragmatic use. And I sort of have understood within my work within the hospital that actually if I use data and prediction as the gateway drug, that seems to work. That if I use the words AI and machine learning, that I just lose people. Yeah, so interesting finding for me. And so in the the other half of this presentation, let's speak about the little bit that I am doing in terms of using mathematical models, right? So I did a lot of work with the mathematics department at Imperial during COVID. There was a lot of pressure to be able to understand the transmission of COVID. How do well patient overlaps drive COVID infection? How do risk factors at patient level um, drive the incidence of infection within that patient? And so I sort of started to meddle with mathematical models in about 2020, right? And the way in which I am currently using it, is to look at simple prediction models where the data is risk factor data. So trained on, for example, the infection, the history of the patient, the antibiotics prescribed, the hospitalization history, but actually noteworthy, the number of accumulated contacts so in between patients, and how do they affect the chance that patient is at risk more or less of infection. Um, so, um, uh, the work that I was doing at Imperial has now budded off into a startup being led by Ash, who was one of the mathematicians who worked at Imperial. The company is called Next. And what we are trying to do essentially is that is to build a one-size-fits-all prediction framework, which has been really hard. But to look at how do you build a framework that can utilize with small amounts of tweaks any EPR, so any record system across the NHS, be trained on the clinical data at patient level, the microbiology data at patient level, the layout of the hospital. So where are the wards? Where are the sinks? The number of the number of the beds per ward, etc. The patient contacts, the water positivity rate, and the prescribing of antibiotics, and shove them into um, a front end so that we're able to figure out when and who and where is at most risk of a outbreak and of which bug. And more importantly, actually, is to understand the level or the likelihood of risk at each patient level, right? And to be able to build scenarios within that framework to be able to decide on patient flows, uh, which I think is, so in terms of where the NHS is, might be more applicable. Um, and so the work that I'm trying to do within the next within the next year or two is to bring together the the data that we have in CareFlow. So this is the electronic records of the patient, along with the WinPath data, which is the microbiology data, and the pharmacy data, which is within RX Info, to be able to move the organization in a very small way, so drip by drip, from one that is very used to um, to moving from the manual collection of data and then visualizing it in Excel, to be able to automate the workflow so that it can clean, store, share, and be able to visualize as a front end, so that we can look at which patients, which infections, where, when, and how, but also to then work with startups to be able to bring in the models to be able to for them to get trained, so we can start looking at forecasting, right? But not just forecasting the likelihood of infection, but forecasting the um, the outcomes of the decisions that we have had to make within the NHS on a R2R basis. You can hear me clearly? I can see some head nodding. I hope you can hear me.
Yeah, there was a Java update. Don't
Oh,
mind
right.
that.
Okay. Alrighty. Now, this took a long time to bring together, and you know, and um, I almost think that the title of this should not be that machine learning is a small piece of the puzzle. It should be that the use of data is a huge part of the puzzle. And if we should be doing more with it, well, we need to take into account where it sits within what the NHS is built around, right? Which is the patient impact at scale. And so we have to deal with the data interoperability stuff, right? The data quality is really so variable within hospitals, right? Um, um, one of the key drivers, as we know, of acceptability and implementation and ownership is being able to explain and interpret what something is telling us and why. And I think that I've found to be the most the uphill struggle. So for example, for the vast majority of people within the NHS, it is not their job to understand things like things like models, or the way in which we use um, or the way in which we can use and stratify risk factors in terms of their so in terms of how they work themselves to the outcome. And so what happens when the outcome is incorrect, right? Who takes the blame? At what point do you want the clinician to act on the outcome, right? So if I say that this patient is very likely to get a infection, well, do you put resources into avoiding this outcome that hasn't yet happened, right? So these are all questions. And then how do you well explain to the trust board, largely made up of clinicians and nurses, why you got it wrong? And so interpretability and explainability is huge, and I don't think we've got there. There's a huge thing around where we are in terms of our the confused nature in which we do things like GDPR, and the hoops that we have to go through to be able to do that. Um, and of course, I mean, what is really important is if you are going to be using data so effectively, and automation is part of that, and prediction is a part of that to drive the NHS from, a control of disease, to a prevention of disease focused well organization, is you need to look at the clinical effectiveness, right? And that is really hard to have something running that is not proven to be clinically effective, in the NHS, and it being allowed to run as so, to gather this intelligence. So you almost always have the scenario where you have a you have clinical effectiveness within an academic setting being imported within the NHS, which has its own struggles. But if used effectively, um, and by sort of the sell to the NHS is the data can drive the clinical expertise. It can drive us to build evidence around, and actually if done with care, and while we are conscious of patient values, using innovation, we can drive we can drive good patient outcomes. So I'll stop there. Do get in touch. I mean, there was a lot of little bits there that I didn't expand on, but happy to speak about those bits in more detail, so if anyone is interested. Thank you.
Maybe if you stop sharing, we can have you. Yes, yes. Very good. I think we have time for questions, right?
Yeah. Plenty of time for questions. If we have any questions from anyone or any thoughts? Yeah.
Thank you very much for your presentation. I was just wondering, the data you presented with correlations between the water and the patients. That was just a regression, let's say, or I mean, it was an average that you did there, random average probably. But did you try to look at those data with more complicated methods and see if there was more that you could say about the links between the two, or?
So good point. I mean, the short answer to your question is no. And the reason it was a no was because I am largely so driven in my work by uh, of course by my expertise in it, but also the ability for me to explain what I've done to a lay audience. So as part of my work, I work for a public trial where I have to speak to where I have to speak to QCs about this. And so I found it very difficult to even explain the use of regression, let alone anything else, So if you're sitting in a courtroom trying to make the point that actually something went wrong in that hospital, we have looked at all the other sources of infection. We know that these are environmental bugs. We know that they live in the water. Let's have a look at the water. Let's overlay it with the infections. Ooh, there seems to be, quite a bit of overlap. That's more than enough for them to digest and make anything of within the legal setting. And so there was no ask to do anything more. And I'm restricted by what I'm asked to do. Now, within my work within the hospital here, if we had data that was as good as what I showed you, where we have water sampling data, so over time for 10 years in a manner that, say, for example, very simply, you could give a score of 1 to every time you have an out of spec water sample, right? Because we know what a out of spec sample is, and you give it a 1. So if you have 5 out of spec samples, very simply, you have a score of 5, right? I mean, so really, really simple stuff. I could do more with that here within the organization, yes. But my experience has been, or the optimism with which I go into things is always not in line with the context. And the context is, well, this doesn't make any sense to us. How do you explain even something as simple as correlational coefficients to a bunch of, to medics, to solicitors, and to a judge in a public trial? So what does that mean? That means somehow I need to get better at communicating these things. But 2, the question is, are these things inherently a bit more complicated, such that the communication of what makes them so, or what is giving you the output that it is really hard, right? And I haven't got to a point where I've been able to sort of been able to sort of to get ahead of so either. But I would love to sort of do more, but we can't do it now because I'm still bound by confidentiality. But at some point, that information will be publicly available, and then I'll let you know, and then maybe we can do something about it. Because the NHS has huge amounts of data. I mean, as you know, it's not new, but its use is driven by what we can use within the clinical workflow. So if I'm going up to the ward and I'm going to be speaking about a patient who has E. coli, it is multi-drug resistant, right? And I'm going, so what do I say? Well, that bed is a bit too close. You should be wearing that sort of PPE. That patient should be in isolation. So within that sort of clinical, the conversation, you need to make these outputs available. There is no other forum where we can just sit down and we can have a chat about it, right? Because we're either on the floor or controlling outbreaks, or we're on the way to the hospital or back from the hospital home. So the question is, should all of this run in the background? Yes, but there's clinical, there are the clinical ramifications of things when they go well is fine, right? But the clinical ramifications when things start going wrong, in terms of we said something about the fact that water positivity within this area is really high, and actually we know from this model that it can lead to X, Y, and Z, and you ask the division to sort of move funds from so A to B to be able to do something about this outcome that hasn't happened yet. That's very hard to explain to the trust board. So
yeah, I also found interesting that you were considering the average, because for me it looked like whenever you had an increase in water concentration, bacteria concentration in water, that followed after a delay to a very big increase in the number of cases. And so rather than using an average, I would have considered the variation from one point to the other and really try to see there what was going on. And also, I mean, in that case, you can even suggest, and the authorities, that as soon as they see that there is an increase, because I suppose they have a threshold, and they say if it goes over the threshold, we treat the water, to say, well, actually, that threshold should be lowered, because otherwise the number of cases goes too high up. So, yeah, I mean,
No,
but there
yeah,
would
it's
be
a
many ways probably to look at those data, yeah, that should
no,
be.
absolutely, and I think one of the workflows that are challenging is in terms of who does the water sampling, where does the water sampling is done by a third party. So it'll go to a external lab, then come in. So when we have a look at it in the NHS, it's always retrospective. And how do we build that within you know the way in which we look at the data? But yeah, you're absolutely right. And doesn't it flag the important point that this sort of conversation should be happening more? Whereas if you ask the NHS, well, so how many people from the NHS are in fact or do have the time to have this conversation, with you about the data? Very few, right? So how do we collectively build intelligence, and how do we collectively work together to make things better? It's a real challenge.
Thanks.
Any other thoughts or questions?
So I guess what I didn't really get at this point is how do you see us helping you, or how can we help? Because I have the feeling that, so for example, my colleague here suggests something about possible analysis, and you respond with, well, how does that percolate into the NHS, which seems to be beyond our pay grade, right? So what is it that we can do, or what is it that, or how do you think we can help? So for example, I was looking at some of your, the pathway data. Immediately it occurred to me that this would be very nicely looked at from the paradigm of temporal networks, for example, which I think could lead to I mean, the spatial temporal aspects is quite interesting. So I can see how give you some insights, which could lead to some models that could help you try to get insight into how this kind of pathway, particular trajectories lead to particular outcomes. But then what I hear from you is, well, nobody in the NHS will act on it. So what? So what do we do then?
So first of all, so appreciate the olive branch, because I think so let me give you some context. So at Imperial, because I worked for academic the Health Sciences Center that came under the Health Protection Research Unit, the mathematics department, the infectious diseases department, the microbiology department, the public health department within the university, and the NHS work together. So I couldn't have done half that work that I did there, or the work that I do with the startup, without being very closely associated and having access to the mathematics department, right? So I think one of the ways in which I mean, as next steps would be to realistically think about how, as someone who works within the NHS, and I also work within the Department of Global Health and Infection, what are the frameworks that we can use to work together? And by that I mean that if, like your colleague, I I have presented some data and you have immediately gone, actually, these are the ways in which you could glean more from it, right? What is that framework within which we work? Do we have to have it as a research project? How do I share this data with you? How can we work together towards a output? And then my question would be, would that output be purely academic? Or can we, as I'm very keen on, look at look at something that is implementable within the NHS, right? And so I can give you all the context with regards to the clinical workflows and where that might come in. But no, I am completely well open to working across the specialties. And I didn't want to say that the NHS won't listen. I really wanted to say is that the NHS really does not have the time. And so whatever we present to the clinicians and to the nurses and to the surgeons and to the trust board and to the chief medical officer needs to be bite size, needs to have evidence behind it already, and needs to be palatable, and having thought of the patient the patient outcomes and the ramifications of the usage of their data to this end. That's the challenge. It's not impossible. Well, clearly it isn't, but that's the challenge.
Yeah, so, I mean, you are mixing a lot of things here in my mind. So there are some logistical things, and then there are some things that are purely NHS. So, I mean, there are people in this room, I can think at least of 3 or 4, who work closely with clinicians already at University Hospitals Sussex. And these things take different form. Some of them are by, I mean, of course, we have the Joint Clinical Research Office, which is supposed to help set things up. There is the Health Research Partnership. There is that.
Yep.
In terms of data, because you have mixed data as well in the lot. So, I mean, data, ethics, there are different approaches. So, for example, I'm involved with a clinician who has amended their clinical trial ethics to specifically cover the transfer of information to us. Now, that might not be the best way of doing it. In fact, the hospital is thinking, is there a way to have an umbrella NHS approval so that any data can just be shared, which apparently is also done at King's. But I think if you just look at all of the issue in one go, that makes it sound like it's insurmountable. And yes, it's insurmountable if you just look at it as one person taking on the world. But these things can be broken down, and they are being broken down. People here in this room are working closely with clinicians. Now you say, is it going to be purely research, purely academic, purely academic or clinical? Up to the clinician, I would say, right? I mean, we are academic, right? So we will not be the sponsors of clinical research. We are not going to be running clinical trials. We are not going to change policy making in the NHS. Right, so that you can't put that on us, right?
Yeah, absolutely.
I would say that as academic, and I would say all the people in this room, we are more than keen for to go beyond just papers. For us, having a paper is great. Changing lives, much nicer, right? So it's again, so, I mean, I'm going to give one example. You look at the literature in cardiac electrophysiology, there are literally thousands of academic papers. When you talk to the clinicians, very little filters through. Very little. It's like, at first when you listen to the clinician, you are almost told there is no research, no academic research. And then you start doing your homework and you go like, my God, this is this huge amount of literature. What are you doing? And it's risk, there is risk averse, which of course is right.
Yes.
Clinicians should be a bit risk averse. We don't want them to try every, random AI and then say, oh God. Yeah.
There's regulatory issues as well.
Yeah, sure. So, but I think it, there's a lot that is possible, and
Yeah, absolutely.
but one of the things is often the onus is on us to learn the language, and that's another barrier, right? Because there's almost an attitude at times of the clinician to say, well, I don't understand any of what you do.
Yes.
And then
Yeah.
how do we get into the domain knowledge? We then have to learn as if learning, electrocardiology was much easier for me as a, I've been
Yeah.
mathematician than it is for them to understand what AI is. Right? Well, it's the same. I spend the time, they don't.
Yeah. Yeah, and I think the way in which sort of, so you're absolutely right. So one of the conduits are people like me, right, who are given posts that are across the university and the NHS to drive implementation and to drive this kind of work. Because as I said, 99.9% of the people within the NHS are doing, are clinically focused. So actually, for those who are able to sort of, to bridge that gap, I guess the onus is on me and so on yourselves to work together and to look at and how we can work together. And you're absolutely right. My summary of chucking everything together, going actually it's impossible, is not the right attitude. Actually, yes, we can break it down. I blame my pessimism, but actually yes, let's be well optimistic. Yeah.
So a couple of things which might be interesting that maybe some people in the room aren't aware of is the work that Liz Ford and others have done on the Sussex integrated data set, which is a second SID. Obviously, we've got SID presenting to us, but the Sussex integrated data set is an anonymized data set. There's also a more general secure data environment where you don't get raw access to data, but you get a terminal access to data, and you get to run models and retrieve models and summaries and results. So these are different ways in which you can operate with healthcare data without having to jump through too many hoops. Now, if you're in a situation like Luke and I are in, where we often have to work very closely with specific clinicians who own that data in order to understand it, then it's a little bit different, the process. But if you're working with more general things, as like James Van Eperen and Maths has done, then you can just use these kind of secure data environments because it's kind of the big picture data, probably similar to sorts of things you're interested in, Sid.
Yeah, absolutely. Yeah, absolutely. Because yes, and really good point, because once I segued here, the work that I have planned over the next 8 months is to actually take C. difficile as the example bug, and working with the data from the SDEs, so working on from the hospital data and the community data for microbiology, for patient pathways, for the prescribing of antibiotics within the sandpit of the SDE, along with Liz Ford, to work on aggregated information from the region. So yes, I mean, I think even for me, that has been a mindset change, that I don't have to work with patient level information, that I can work within structures like the SDE and the outcomes are equally valid. Do you see what I mean? So I think the more communication we have about these, and actually we are really, it's so good that we have the SDE, and the fact that our SDE is so much more advanced than so many others. Yeah, and I think, well, as I grow and learn more about what you guys are doing, the relationship between at least me and a few others within who bridge this, the NHS, the academic gap, will be more fruitful. Yeah, so I look forward to it.
Any other thoughts or questions?
I said, very practical question. With your spatiotemporal mapping of the infections, have you considered or been able to supplement that with rostering data to see whether there's a person-specific impact as well? And have you been able to expand your spatial axis to include regions which aren't just the post ward, such as going to different imaging departments or that sort of additional level, to see whether there are further intersections between at-risk patients?
So really good point. I mean, I've sort of recently got my head around, well, somewhat, in how to feed this data into a what do you noted this a more not a patient pathway model, but what do they call but when you have the nodes and the intersections will coming out from the nodes? Yes, yeah, exactly that. And it looks very promising. But I would love to work with you to look at this more, because wouldn't it be great if we could do a piece of work where we retrospectively look at the data that we have either within the SDE or within the hospital, to look at how we can build these sorts of networks for data for the past year, because yeah, I mean, it would be hugely helpful, because at the front door for that matter, so much of the pathways and the accumulated risk of those patient pathways, so of which there are numerous, we don't know what the impact of those pathway the tweaks are, because patients jump from ward to ward to ward, right? So yeah, I've looked at it, but just at the starting stage. So I would love to know how I can further these conversations, right? I mean, how can we do this? So food for thought, and yeah, I'll connect up and go, well, how do I work more on this with you guys?
I think one obvious thing is to, for example, have a data science MSc project. This is the obvious thing. What we've just talked about will be a perfect MSc project.
Okay.
He's saying, look at you have access to some historical data of contact, and then you are interested in, because once you look at this from a network perspective, you can start looking, for example, at properties of the network and whether the appearance, say, of giant component or whatever is correlated with things happening at infectious level. So if the simple hypothesis would be, well, not an hypothesis here, but that your input data is these pathways, and then what you are trying to understand is whether what happens on that network over time is predictive of what's happening on infections of interest. And that makes a perfect MSc project.
Okay.
Is the issue that this is potentially identifiable data if it's patients from more?
Well, again, you can't ask the academic to deal with that. Yeah,
No, but
I mean,
it's not about giving it to an MSc student. Well, it doesn't matter whether it's at that level. Even you as a supervisor, you have the same problem. So really, the issue is whether this data can be released to us. If it can be released, it doesn't matter whether the MSc or us.
I mean, if it can't be released, then you can access it from in a secure data environment, because then you don't get that.
So that's that.
To get into the SDE, the Sussex SDE, the data needs to satisfy us. I mean, it may not be that this data can be put in the SDE depending on.
I guess that's Sid's job to resolve.
Again, it's their job.
Yeah.
So
Just talking about data.
Yeah, no, but I mean, but I mean, these are really the things that I'm grappling with. And yes,
two things I may be able to add. So one of them is this sounds like you should be able to fully anonymize an extraction of a sub cohort of that data under the concept of a service evaluation, and then if it's fully abstracted, then it shouldn't have any risk of identification, because really all you need, I imagine all you need for your network analysis is patient 1 to X, ward A to Z, and the like. So that can be fully abstracted. And actually, if you're just trying to understand how the interactions work, you are evaluating your service. That should be able to get through under the Sussex Service Evaluation Framework. If you do it as a select time period, six months ago, a year ago, 2 years ago, etc., because it will have no direct influence on patient care, and so that should be very feasible.
Okay.
The option you have, as back to data science MSc, is you could look at potentially upskilling some of your IPC nurses using the Sussex Research Internship Scheme. That provides 20% plus.
Oh, you're right, because actually
time to upskill a clinical person to do research. So actually, if you want to bridge that gap, it might be that you need to pull the clinicians to you, as well as supporting them with the data science MSc student, so that they can work together to bridge it. You can also think of having an implementation phase where you maybe get a PhD student to add in, say, ward testing of the outflow pipes to see whether you can add to your models, and do that through a PhD scheme within a subset environment, because then you have a fully funded pilot, which you can then use to, say, go to NIHR I4I scheme to look for further implementation.
Yeah, a really good point.
Developed a concept.
Yes, because I think some of these conversations have been had, but actually are being had, so in terms of or within how the Sussex Research the research partnership group falls, and its role to promote this sort of work. So yeah, I'll definitely have a conversation with James Price about that, and with yourselves about how we can make that happen.
That's great then. Thanks, Sid. I think we'll wrap that up there.
Okay.
Much for your talk. Thanks everyone.
No, absolutely. So nice to to talk to you guys. No, thank you for that.
Thank you very much.
All right. Right.
Bye bye.
You were right. There's no other.
And that's